Thank you, and it's a pleasure to be here with you today and have the opportunity to share with you the Quality Quest for Health of Illinois work on specialty care measurement and quality improvement. And I'm going to ask Joy Dooling if she would do me one favor and pick up a packet of the handout that I brought, because I have it in my briefcase, but you don't want me going and digging for it right now. I forgot to bring it up with me. Oh, she's not in here right now. Will you? It's they're collated like this. And there are three things. I want to use those. So we do in Central Illinois, Quality Quest, individual physician reporting on colonoscopy. It's a procedure. The doc does it, and it's done at one point in time, so it's really appropriate for this to be reported at an individual clinician level. We are a regional collaborative. You've heard about that, so I'm not going to go into any detail, but I think Elizabeth really alluded to this bottom point here, which is no body, no one is in charge of health. There's nobody in charge of health care. And so this is a means of local regions taking charge. Somebody needs to take charge, because we're getting such poor value and results right now that it's just unconscionable, and we have to do a better job, and we change care where we live. So screening colonoscopy, each year, this is data from the American Cancer Society, about 4 million people in this country get a colonoscopy hoping to avoid colon cancer. Based on the Blue Book, at healthcare price, it's $1,120. It's a lot more expensive than that in some places. I don't think that there are many places where it's a lot less expensive, but that adds up to $4.5 billion of spending on colonoscopies annually. According to the Cancer Society, there's still 40,000 to 50,000 people who die every year, deaths that could be prevented by screening for colorectal cancer. So you'd say commonly what would be interpreted is we have an underuse problem in this country. Well, we do have an underuse problem in this country, but we also have an overuse problem. And that's, I think, what we miss when we talk about a lot of healthcare things, is that they coexist. We both underuse and we overuse everything at the same time. And so a big piece of what we've done in Illinois is to say we're going to nail it, we're going to get it right. And you'll see in the presentation that appropriateness is part of what we do. And the GI doctors will admit that we really don't have a very good system for, this is head of the GI Society, and then, you know, it's really unregulated. There's no data. So in 2007, so think back, this is a long-standing project now in Central Illinois. 2007, the colonoscopy team was convened. We used the Six Sigma process. Stakeholders, and you can see it's multi-stakeholder here, lots of docs around the table, also consumer and employers, and they said, what would it look like if we really were doing top-notch work every single time? What were the things that would be? So they go to the literature, look at the GI Society guidelines, look at the science behind those, and they created standards and converted that into a performance measure. And this is what's in the measure. And I think that this is a concept that is really, really important, is that you're trying to get the whole thing right. So I'd say, who among us would want to go in for a colonoscopy? We'd say, well, I think if they got 6 things right out of 10, that would be just dandy. I mean, nobody, right? You need to get it all right. And so the things that are in there are, the patient actually needed the test they're having today. That's a hard one. Complete exam of the colon, we've done baseline, did quite well on that. Photo documentation that we actually got to the end so that somebody looking back on that could verify that indeed this was a complete exam. Might be the GI doctor who wanted to know that. No serious complications. We shouldn't be hurting our patients, and some of these are unavoidable, but many are avoidable. That the bowel prep was assessed, and that seems like a little process bit, but if the bowel prep is not good, and you call the colonoscopy sufficient, you've not done the patient any service because you really couldn't see what you were looking for. So that's an important piece. Cardiac risk, there's a lot of anesthesia being used in colonoscopy these days. That's an important piece. You need to rate systematically. ASA means the Anesthesia Society of America, and this has been in place in procedures in anesthesia since the early 60s. And we need to be using it in colonoscopy systematically. And, it's pretty good, but polyp information, withdrawal time, how carefully did you look, and then when you told that patient to come back, was that evidence-based? So we built a measure, it's all or none. You have to get it all right in order to get a positive score, and taken together, it really reflects high process reliability. It's what we want, and it's based on $4.5 billion spent. It's what we should be expecting. And so we've been collecting data. This is direct data submission, so the endoscopy centers sent us a file on a quarterly basis of all screening and surveillance colonoscopies, and we collate that across endoscopy centers because one doc might go to multiple centers. So we then report by the individual clinician. This is a picture from the website. And these on the left upper box are the top performers, and the right lower box are the lower. And it's too big to put on the slide, so so we just took a clip of those two things. But in addition to that all or none measure, all of the individual elements are reported also by individual doctors. That was important for the clinicians. They wanted that information out there too, because those look much prettier than at baseline than the index. So what happens is that in my experience, and I suspect in yours, every time you make data, good data, public, care gets better, right? Provided that you're measuring something that has a gap. I mean, if it starts at 99%, it's like, why waste your effort? This is an expensive, hard work endeavor, and we shouldn't be measuring things that are simply congratulatory. We have to be measuring things where there's a gap in care. And so when we started, the baseline was about 50%. Half of the colonoscopies were missing one thing or more. For many of them, they were just one thing. But for others, they were two or three. When we started public reporting was in the third quarter of 2010, and you can see what happens. And this happens every single time. If you want it to change, you have to be transparent about it. And then I saw the portal that Mylea and Jim talked about. This is also a portal, so physicians can sign in and see patient-level data, which is encrypted. I don't know who that patient is, but they do. They can go back to the institution where that patient was taken care of, and they can find that. And so everything here is the zeros are defects. So we only report in the portal cases where there's one or more defect. They can go back and see, were we right? Was that data reported to us accurately? And there, for the most part, it's been really very accurate. Once in a while, there was something where the clinician disagreed, and that was a good point, and so then you need to go in and really refine your measurement specs, do that last little bit. So, but again, it's their measurement. So we need a system solution. I'll tell you what my dream is for colonoscopy is that we get beyond quality by exception in this country, and we really do this one right, and we could do it. We could do this in this country in just a very short period of time. Because, did somebody bring me my papers? She handed them out. Everybody has them. Everybody has them. Everyone has. Okay, great. So I want to show you on the third piece here. This was for our NQF measurement submission, so we have the colonoscopy quality index into NQF for endorsement at this time. And I wanted you to go to the last page of that right here. So the GI societies have registries. The two big ones have registries that they're making commercially available. And those registries, if I do a crosswalk between our measure elements that we get from the endoscopy centers to report this measure and what they have in their registry, there is a gap. The gap are these data fields right here. And what you can see is that they are primarily history. It's all about taking good history. And that's the piece that you need to determine appropriateness. You need to know what that patient and that family history is and what's happened before. If the GI registries were to expand to include these simple history elements, these elements. This measure could be reported from the GI registries, and it could be done everywhere. And you would create the capacity to screen the people, the 40 to 50,000 deaths that we currently think we don't have capacity in the GI system to do. You'd create the capacity by stripping out the 10 to 20% of people who are getting procedures today that they don't need. So I didn't tell you where the gaps are. The gaps are they're being done too soon, too frequently. They are not sending complete information to the pathologist, really important. If I have a polyp taken out, I'd really like that pathologist to have everything they need to know to interpret it properly for me, and so would you. And then when they tell them to come back, it's often too soon. Those were the baseline errors. The rest of the stuff is being done quite well. But that's not a reason to leave it out. It's all important. So that's what we've done in Illinois, and we say strong quality measure, aligned incentives, public reporting, reputational incentives, very important for doctors. You know, we're competitive. Financial incentives aligned with that, big deal, makes a difference. Caterpillar stepped up to the plate on that one. Get the registries to capture everything you need. Get the EHR vendors to update their system so it can ship it out, because right now they're clumsy, they don't do that. But unless we ask for the right measure, we're not going to get those last two things. We won't get it. And we could have this. It would be so easy. Not easy, it's a lot of hard work, but it is imminently doable and scalable across the country. Save lives, save money. Thank you.